Hello everyone. Hello everyone. This is Sarah here. Thank you very much for joining the webinar today. During these uncertain times of a pandemic, such as the one we're facing today, when fear and panic is spreading faster than the contagion, it has become extremely important for us to ensure that interpretation and communication of scientific information is accurate, timely, and more importantly, understood well by the public. And it is with this view that we have put together this webinar for those at the front lines of disseminating information to the public. These are our journalists, community reporters, and other media professionals. Your work is of immense value when we are battling a global health crisis and we understand the pressure of reporting correctly. As a journalist, community reporter, it is important to have the right information to do the job well. Please see this webinar as an opportunity to clarify your doubts and prevent any misreporting. Now request Devalina to please share the housekeeping rules and also introduce the speakers.
Right, thank you so much, Sarah. I do want to quickly take you to some of the housekeeping rules and want to share that this webinar will be recorded and we will also be sharing this webinar widely. If at any point of time you have any questions, you will be seeing the question box on your right in the panel. Please do submit your questions using the question box or the chat box. Also, as a note, please note that the panelists are providing their views on the current situation as scientific experts and as journalists who are working on this issue closely. They're not speaking on or behalf of the government or associated organizations. I would now like to invite the speakers. We have with us Dr. Jamil, who is the CEO of DBT Wellcome Trust India Alliance. You all know Dr. Jamil as a virologist who's globally renowned and is known for his research on the hepatitis E virus. He is also the fellow of all three Indian Science Academies, which include National Academy of Sciences India, Indian Academy of Sciences, and Indian National Science Academy. Today, we also have the privilege of having Dr. Gagandeep Kang with us. He's the Executive Director of Translational Health Sciences and Technology Institute. Dr. Kang is a medical scientist and has worked on diarrheal diseases, especially rotavaccine virus. She has been a key contributor to understanding of rotavirus epidemiology and vaccinology in India. She was a recipient of the Infosys Prize in 2016, and last year she became the first woman working in India to be elected as the Royal Society of UK. She is currently the chair of National Technical Advisory Group of Immunization and vice chair of the Coalition of Epidemic Preparedness and Innovation. We also have the privilege of having Shubhra Priyadarshini with us, who is an award-winning science journalist and is the editor of Nature India. As you know, Nature India is one-stop site for information on Indian science. Though she has many years of experience spanning across different genres of journalism and mainstream media, her first love is science journalism, and over the last decade, she has worked very closely with the journey of Indian science and technology. Shubhra actively contributes to the cause of science communication and scientific temper. We are very privileged to have all these three esteemed panelists today to speak to us. I would also like to remind you that please use the question box or the chat box to type in your questions and comments. Over to you, Shubhra, Dr. Kang and Dr. Jamil.
Shubhra, you're not audible.
Yeah, thank you, Devlina. I think I'm audible now. Am I audible now?
Yes.
Yes, you are.
Okay. So I was saying that by now there's no doubt that we're looking at one of the biggest pandemic of our lifetimes, certainly something none of us was prepared for. I've been in science journalism for over 2 decades now, and I haven't experienced a scenario like this one in my reporting career, in my journalistic career. My co-panelists of today, Dr. Jamil and Dr. Kang, may also not have seen anything similar in their lifetimes as scientists. This is exhausting for all of us at multiple levels. And so thanks everyone who has come together to put up this show and to hear us speak about this pandemic that's looking at us in the face. Let's just admit upfront that there are many, many questions about this pandemic which we do not yet have answers to. But we will try to make sense of whatever information is at hand right now. Though we wanted this webinar to be primarily about the media, we have many of them joining us today. There are many science questions that have come up, which is great news and is indicative of how gripped everyone is with the story at hand today. Public health administrators, researchers, essential service providers, and the media all are having an overwhelming time attending to the call of duty individually. Of all of these, I think the media's job is among one of the toughest right now, especially since we are dealing with multiple unknowns. And through these imponderables and uncertainties, one has to make sense of a mammoth amount of scientific and purportedly scientific data, government briefings, which many a time reveal as much as they don't, which is their mandate, of course, in trying to balance what information can be made public in such a public health emergency. Then you need to parse through tons of fake social media messages and look for the relevant ones. Do the on-ground Hydra-headed reporting on the political, economic, and social impacts of this pandemic, and yet remain relevant in your stories for your audiences, not making it too panic-stricken or utopic or even academic. So you want to avoid lulling people into complacency, but you also want to not hype it up so much that you create unfounded fear or panic among people. So how exactly can the media shape the conversation and action around a fast evolving story like this, like COVID-19? What are the things that regional media houses should do and do not to create awareness among the larger audiences that may not be aware of the ills of what's happening right now? We'll discuss all of these and some more in this webinar today. And along the way, we will also try to bust some of the common myths too. So amidst all this gloom and doom, let's perhaps start with a news point, a question, an answer to which many of our listeners from the media or otherwise want to know. I'll hand it over to you, Dr. Jamil and Dr. Kang, to discuss a little bit about the drugs and vaccines against the novel coronavirus SARS-CoV-2. The WHO is now looking at India to replicate its success in eradicating polio and smallpox, as we know. What are the three things, or what are the things that India should now be doing to make sure this mammoth population understands the gravity and enormity of the situation beyond what is already being done, of course, right now? Also, India's health ministry has okayed the use of the anti-malarial drug hydroxychloroquine for treatment of high-risk coronavirus patients. We also have some anti-HIV drugs being tested on COVID-19 patients. What evidence do we have around it? What vaccines are being developed? When might they be? Of course, we know it's a long process, but when might they be available to us?
Subra, let me attempt the treatment question, and I'll let Sherry handle the vaccine because her work through CEPI, I think she's better placed to speak about the vaccines. The government of India has allowed use of chloroquine But I think it's important for us to understand that this is only in people who are in hospitals and who are very sick. This is also, we must realize that this is also based on a small study, which is not truly a case controlled study, only 40 patients in a French study. So one needs to exercise caution. Uh, those of us who understand how chloroquine works are not surprised that it's showing an effect, but people are going a little overboard thinking that they can pop a chloroquine once every week and they will be protected. They will not be protected. Uh, what they will do is land up, uh, you know, injuring themselves, messing up their livers and their kidneys. So please do not take chloroquine as a preventive. Chloroquine has only been allowed, and I again emphasize that there is not enough compelling clinical evidence that chloroquine is a sure shot drug in this case. All right. Besides chloroquine, there have been some other drugs that have been tried. So, for example, there is a drug that was developed against SARS in Japan, and this drug was put in the cold storage after SARS disappeared. This has been tested in China, and this drug seems to have given good results in patients in China. And now Chinese have acquired the rights and they are in the process of licensing this drug. So there are various experimental therapies being tried. So far, we need to understand that all of these can only be administered in a clinical setting by doctors. These are not self-medicating therapies. Cherry, I'll pass it over to you for the other stuff.
Sure. So in terms of vaccines, it's actually an incredible time for thinking about interventions, how quickly information is coming in, how much scientists are working together, and how we are applying both science and technology to new interventions. I've never in my entire 30-plus-year career seen things move this fast. I've never seen this much sharing. When it comes to vaccines specifically, there are about 40 programs, a little over 40 programs globally that are looking at vaccines. And CEPI, to which Shahid had referred, the Coalition for Epidemic Preparedness Innovations, currently has 8 different projects. So the first 3 projects were sanctioned in January, and since then, CEPI has been building new programs and announcing new collaborations. So we are up to 8 now, and I'm anticipating that we will have at least 2 to 4 more companies and groups that CEPI will work with, including, I hope, groups in India. The thing about making vaccines is that vaccines take a long time to develop. You have to have a proof of concept, and usually you develop that in model systems. You usually go from cells to small animals, sometimes to large animals, and only then into humans. Now, we have all heard that one of the vaccine candidates in the US and one of the vaccine candidates in China are both in human clinical trials. And what the regulators have done is that they've said that there is adequate evidence from the platforms on which these vaccine candidates are based to be able to say that these are likely to be safe in humans, and it is possible to do human and animal studies together. So the US FDA and the Chinese regulators have both agreed to that, and these studies have started. The first step in a study is always assessing safety in participants, and it's anticipated that the safety studies themselves will run to the middle of the year. And in the safety studies, there is an intention to look at immunogenicity as well. After that, we'll be able to look at what the design of future trials should look like. By the time these studies end, there will be many more candidates that will have entered human trials. Now, in terms of the technologies that these 40 projects are using, I think it's important to remember that most of the vaccines that we have licensed today work on technology that was essentially 50 years old, 30 years old. There's only one vaccine that is licensed based on technology that's been developed in the last 10, 15 years, and that's the meningococcal B vaccine. And then most recently, we had the Ebola vaccine that was licensed by the FDA. Now, the meningococcal B vaccine is interesting because it's the first vaccine where the protein was designed based on the sequence of the infectious agent. The Ebola vaccine is interesting because it is the first vectored vaccine to be licensed. And these are the only two new technologies, the MenB for global use, but the Ebola vaccine still only has a license under a special provision allowing for it to be used in areas where there are outbreaks, not in the countries that actually license the vaccine. So what we are going to see is a lot of human testing, a lot of approaches to evaluation of vaccines, and a need to work with regulators to be able to get these vaccines developed as fast as possible. From the 40 vaccine candidates that we have, I'm not anticipating that we will see more than 2 or 3 approaches actually winding up being successful and making it through to licensure. So it's important to be aware that vaccine candidates sound good when they start off, but they are not an immediate solution, and many of them will fail. In terms of timelines, the Ebola vaccine was already ready and had been tested in humans in phase 1 studies before the Ebola outbreak of 2014. And the vaccine was licensed only in 2019. So global effort allowed for that vaccine to be licensed in 5 years. Now we are hoping that with this approach, with the number of people that are infected, the many different candidates, we will be able to shorten that timeline as much as possible. But I think 12 to 18 months from now is a reasonable time frame if all goes well. If it doesn't, obviously we need to be looking at solutions we are using today as well as the drugs that are currently being tested.
Shubhra, if I can bring you in, since this is a webinar mainly for science journalists, people who are writing on these stories. If you could go through the do's and don'ts for journalists before we proceed further.
Sure. We have been seeing a lot of coverage of COVID-19 and the virus itself, the scientific aspects of it, and rightly so. This is the time to really amp up coverage on the pandemic that's gripping all of us and our minds. So the things that we as science journalists across the world do is to follow guidelines around what some key institutes and agencies have put together, going through the pandemics or epidemics or outbreaks in the past and compiled guidelines around them. So the Poynter Institute of Media Studies in California, the Global Investigative Journalists Network, the AFP Style Guide, the Nieman Lab, the International Center for Journalists. All of these are, fora and platforms which have put together guidelines around the do's and don'ts of reporting in times of a pandemic. The basic idea in all of these guidelines is to stick to evidence while treading the fine line between underplay and hype. Also to make sure that journalism aids the active public health discourse in eliminating this disease from the face of the earth. So really the role and impact of our journalism becomes decisive and informs public policy, elicits action more now than any other time. And at the same time, as I said earlier, there are some questions to which the public health administrators themselves may not have answers to right now. And they are also trying to cope with the huge scale of the invisible enemy in front of them. So really asking those questions backed with evidence and not just anecdotes is the key to help guide these discussions. One of the examples that I wanted to put forth about this is Karen Wall Horhensen, a journalism professor at Cardiff University, has examined how fear has played a role in COVID-19 coverage in 100 high circulation newspapers from around the world. She has found that 1 out of every 9 stories on the outbreak mentioned fear or related words, including afraid. And these stories often use other frightening terms like killer virus. So we need to really understand the fact that responsible reporting would mean reducing the use of such subjective adjectives in reporting. For example, deadly disease. Every virus may not and will not be deadly in those terms. To use pictures that go along with those stories very, very carefully so that they don't spread the wrong message, to explain the preventive actions that can be that can make your story a little less scary. Also, statistical stories are always less scary than anecdotal ones. So probably bring in statistics which we know can be bent anyway, but still, if you have the numbers to go with your anecdotes and human stories, that makes much more of an impact with people and less scare. So those, and then avoiding clickbait headlines. Come on, this is certainly not the time to get audiences to read your story by using clickbait headlines or terms in your stories. So developing a solid grasp of the science also, especially the medical and the public health dimensions, by talking with experts and reading extensively about the issue. Trying your best to communicate the problem in simple language, as simple as possible, but without, of course, simplifying the problem itself. So you provide enough context in your writing and reportage to do that. In these times, people also want to know what to do. What can I do? What should I do? And even if you have written about and reported about the recommendations and basic hand hygiene or social distancing or physical distancing as it is being called now, 100 times, go at it, keep doing it. The misinfodemic phenomenon, which is the misinformation epidemic, and how agencies can and should handle it is also a big question that's looming at us all. So some of the credible sources that I want everyone to guide to today is the AFP fact check website. So the minute you get a WhatsApp forward or a story that appears fake, or that something that you think you should cross check before forwarding it to other people or telling other people about it, a simple Google search many times reveals the origin of the story. So somebody already has done that fact check on Google probably and seen that it's fake. So 90% of the stories you can simply squash by doing a simple Google check. If it's not there, go to the AFP fact check platform, the WHO Mythbuster platform, the US-based Centers of Disease Control, and the Public Health England platforms. There's the Indian Ministry of Health and Family Welfare, which is also busting myths on its website now. There's Alt News too, which is got popular in the recent times, which does a fairly good job of busting every single myth that is floating around. And a dedicated portal, which we also highlighted in one of our Nature India coverages, is the Health Analytics India platform, which is solidly backing every fake story with evidence and sort of busting it. So that, in short, is something that the regional media, and I want to just mention that among us, we do speak a few languages, and if there are any listeners who are from the Hindi-speaking region and cover the story in Hindi or Bangla, Oriya, Urdu, we are happy to take any of those questions in those languages if there are any listeners. Talking about myths, since we have the experts on this webinar, let's also bust some of those myths right here. So Dr. Jamil and Dr. Kang, two of the myths that I have problem explaining to several people over these couple of weeks, including my own parents, have been that COVID-19 actually, the virus escaped from a US or a Chinese bioweapons lab. And so it's China's design to destroy the world or something like that. Those stories are doing the rounds effectively, I must say, because lots of people are believing in those stories and asking those questions of us. And also the fact that the pandemic hits in the 20s every 100 years. So 1720, it was the plague, 1820, it was the cholera, 1920, the Spanish flu, and 2020, COVID. So much as it is such a wonderful sort of coincidence, what's the evidence behind all of this, and what do you both have to say about it?
Sherry, I'll let you take care of the conspiracy theory. I'll take the 20s.
Sure. The conspiracy theory is quite widely circulated. I mean, people do say the virus was released from the Wuhan Institute of Virology, and I have to tell you that the Wuhan Institute of Virology has truly outstanding virologists. So the quality of the work that they do is very good. The other one is about the US actually taking the virus to China and releasing it at the military games that were held in Wuhan in October in 2019. We now have evidence from a lot of sequencing studies that have been done. One of the good things about this particular outbreak has been how ready people have been to share sequences that have come from viruses around the globe. And those sequences have been analyzed by people who really know what they are doing. Now, the nice thing is that, if a virus is modified, you can tell that a virus has been modified because there will be signatures. The ways of modifying a virus are understood by virologists. So you'll be looking for evidence of modification, and people have done that, multiple groups now, and they have said that this is not a modified virus. This is a virus that has evolved over time, as RNA viruses do, and its link back to viruses that are found in animals is evident, but a link to it being an engineered virus are not. So there is really, based on the best analytic techniques available today from reputed, credible virologists from multiple laboratories, no evidence that this is actually a bioweapon. Shahid, over to you for the pandemic theories.
Yeah, so before I get there, let me also say on this this myth that the US sent this to China in the military games. I had a person on one of my WhatsApp groups who was really insistent that this is how it went there. So I had two questions for him. I said, how many of those American soldiers fell sick and how many died? Find me that number and I'll believe you. He stopped bugging me after that. So coming to the theory of 20s, this has been going around that the plague of Marseille happened in 1720. The great cholera outbreak in South Asia, Southeast Asia happened in 1820. The Spanish flu happened in 1920, and now we have COVID in 2020. Well, I don't remember about 1720, 1820, or even 1920, but I've read a little bit about 1920. And most of you would have read that too, that Spanish flu didn't actually start in 2020. It started in 1918. So it lasted from 18 to 20, and it was soldiers returning from World War I that took the virus around the world. So this whole theory about a pandemic happening once every 100 years, I think by this token we should have been ready. We should have prepared for a big one. We should have prepared our hospital capacity. We should have prepared everything. We are really big fools not to have done that. Having said that, I think it's important to understand that when you disturb the ecosystem, these things will happen. When when you keep destroying forests, there will be more animal-human contacts, and because of that, there will be a higher probability of viruses in animals getting into humans. Now, we are, there are a lot of responsible people who are saying climate change is rubbish. We have evidence that glaciers are melting, permafrost is melting. What will come out of these glaciers when they're melting? We don't know. We don't know what's hidden under that. So I think that if there is any lesson in this, the lesson is that we should really be taking care of our ecosystem. We should really be taking care of our world, and don't just throw out opinion of science based on your beliefs. Science is something which is a matter. Science rests on doubts and questions. Religion, on the other hand, rests on belief. Please go ahead and believe in whatever religion you want to believe in, but still, please do listen to science. And that's very, very important.
Dr. Jamil, thank you so much. We do have a lot of questions coming in, and I do hear a lot of journalists saying that please take these questions. I'm going to bring in some of the questions that are coming in. One of the questions is, can you take me through how the virus behaves, in what time periods in different age groups of people? How does it behave in symptomatic and asymptomatic cases over the first 1 week, 2 weeks, etc. in different age group? Dr. Kang, Dr. Jamil, any one of you wants to take this question?
Terry,
yes, before that, I would just like to add a couple more questions that I have from this end. Coming to the other question of testing and modeling for future predictions. Many people want to know, when will we see the peak in India? What are the models prevalent now? Which are the ones we should believe? And the question that everybody is also asking is, how many people in India would get infected and how many would likely die of the pandemic? So do we have any clear evidence or modeling or answers to these questions?
So let me attempt the model. You have to understand that models are exactly that. They are models. and they are based on certain assumptions that are valid at that given time. Models always fail when there are uncertainties. Human behavior is the biggest uncertainty. The virus exploits human behavior, and therefore that brings in a big uncertainty. Okay. Having said that, I've heard extremes. I mean, I've heard of one model where about 30 to 50 crore Indians are going to get infected, and there will be 10 to 12 lakh deaths, which essentially means that anywhere from about 25% to 40% of our population will get infected. I really feel that's a bit extreme. I've seen a reasonable model come up by a group called COVID-19 study group, which is made up of some biostats people based in US, mainly Indian students and faculty. Their predictions are that in the best case scenario, there will be roughly 60 to 65,000 infections, roughly 4,000 deaths. In the worst case scenario, it will be about 21 lakh infections and about 13,000 deaths. But again, I will say models are models and they are based on assumptions. Cherry?
So I've kind of been involved with some modeling groups, and I've spent a fair amount of time sitting on an advisory committee at WHO that views models. So one of the things to remember, as Shahid said, is that models are models. And in India, we actually don't have a lot of data because all of the data that we have from patients is really based on the testing we've done so far. And that testing has been limited to imported cases and their contacts until last week. And last week, we had reports of cases where there was no known contact history. And you're seeing a few cases, still a very, very tiny proportion that have no history of contact. So when you look at building a model, what do you need to know? You need to know what is your population like. If you're building a model for India, you need to know how much, who lives where, what is the structure of that population in terms of age, who interacts with whom, if you want to look at how diseases will spread. Now, in terms of age structures, occupations, general nutritional profiling, we have a lot of surveys that have been done in the country that inform the building of models like that. So you can look at the NFHS survey, you can look at census data, you can look at a lot of what is around here and recreate what India looks like. Then you have to layer actual disease onto it. And if the only information that you have on disease is based on incoming travelers, actually what you're modeling is not disease in India. You're modeling what is happening outside the world. And your incoming travelers are a reflection of what is happening outside. Now, if you look at the models, there are currently 3 available models that have been highlighted. One is Dr. Ramnan Lakshminarayanan talking about the model that his colleagues at Johns Hopkins, Princeton, and CDDP have built. The other is the model that Shahid referred to, which came out of the University of Michigan and is led, well, seems to be postdoc students largely. The third is a model that was published by the Indian Council of Medical Research yesterday. So these are the 3 models. And the low-end model is the University of Michigan model. The high-end model is the model that the group that CDDP has done. Now, both of these are based on different things. The Ramanan's group uses the IndiaSim model, which is something that they had built and has been used for a number of vaccine studies. And the University of Michigan is using other sources of population structures, but largely NFHS. Now, the model that the ICMR has published does not comment on what proportion of the population is likely to be infected, what are the numbers of cases, etc. So it has different outcomes. It focuses on what kinds of public health strategies can be used and what the likely effect of those strategies is going to be. Now, based on the models, I think we are going to see the problem again with models is they predict something as being what we will see in an unmitigated scenario where nobody does anything, what will happen. And when you start to do something, whether it is hand washing or physical distancing or doing closing of borders and closing schools and stopping flights, each of those will have an effect that will depress the levels of the model. So when you look at the credibility of a model, you want to see how many different models people have built from what kinds of available sources of information. And then as you get information that is local, you refine the models. So it's a good starting point. It's impossible right now to say that one is a good model and the other is a bad model, and this is likely to happen or not happen. We need data from India to inform our models. It's great that these models have been built, but what they are using is assumptions based on data coming from other parts of the world. Given that this is a viral infection, you don't expect it to behave differently in different populations. The one piece of information that is important for transmission models that we don't have in any shape or form from this country is what is called social mixing. So who interacts with whom for how long, which would be important to refine these data. So most of the social mixing that is in these models is derived from other populations. And we know that we have much greater density in our populations, which means transmission is likely to be high. So modeling is good. Takeaways from this: modeling is good. Modeling gives you something to act upon to predict what kinds of interventions you should use. But as far as possible, we should be looking now at generating data that will better inform the existing models.
Thank you so much, Dr. Kang. I also am getting a lot of WhatsApp messages right now while we are seeing questions here. The question that was also asked was about the behavior of the virus and how is it behaving in different age groups of people. In addition to that, I'm also going to add one more question which says that is there any data on natural tolerance of COVID-19? For example, individuals with ACE2 polymorphism, are they differentially susceptible to COVID-19? I would also request if we can make it as laymanish as possible, because I do know a lot of reporters are right now clued in and they would want to understand it in a laymanish way.
Sure. Well, you know, quite frankly, I think most reporters who are interested about writing on science, whether it is the English press or in any other language, are very quick on the uptake and get concepts pretty quickly. So I'm looking forward to them being partners in this communication process. So the first thing around how different ages are affected, we know now, so the initial thinking was that children don't get infected, but now we know that children do get infected at the same rate as other age groups and seem to see milder disease. As age goes up, you see more severe disease in individuals. Now, the severe disease, we know that as you get over 60, over 70, over 80, when you get severe disease, mortality is also higher. Now, is this a question of how the virus is behaving differently in different age groups? Well, the virus doesn't behave any differently. It is really the response of the host or the ability of the host, the infected person, to handle the virus that determines the severity of the outcomes. And what we are seeing in the most severe disease, which is the respiratory distress, the multi-organ failure that patients get, that is a factor of age. For some reason, when you have a lot of chemical modulators being released during infection, you see that younger people seem to tide through it better. Not all of them, because we know that young people, smaller proportion of young people can also get severe disease, severe symptoms and die, but the proportion is higher as you get older. So that is around the age structures. The second was how are populations immune to or susceptible to COVID-19? We started from a situation where absolutely nobody had seen SARS coronavirus type 2. We have a tiny bit of evidence that shows that there is some cross-reactivity between the original SARS coronavirus and SARS-CoV-2. But since SARS coronavirus infected less than 8,000 people, in public health terms, that cross-reactivity or that protection that people who have been previously infected with SARS coronavirus is not really relevant. There have been recent data that have emerged that have shown that, there is also seasonal coronavirus infections. There are 4 coronaviruses that infect people all around the year. They usually cause just a cold. The SARS coronavirus 2 antibody responses are very different from the antibody responses to the seasonal coronaviruses. So effectively, you're in a situation where you can say that there are possibly 8,000 people in the world that might have some level of resistance to SARS coronavirus 2. Everybody else will develop some level of protection. We don't know how long that is going to be from the infections that they will get now. So everybody effectively is susceptible. And that's why we need to make sure that we focus on flattening the curve and slowing the spread of the virus across countries so that we can cope with it. Over time, all of us at some point might get infected and might develop some level of resistance. Your third question was around ACE2 polymorphisms and whether that makes a difference. I'm not aware that polymorphisms make a difference. It's a great question, and I will look to see whether there is any evidence of that. I don't know the answer at the moment.
So let me also add to what Cherry just said. The age effect that we are seeing in the COVID virus is not something that is unique to this virus. There are many other viruses that show very mild or asymptomatic disease in children, but as you grow up and you get that infection, you get bad disease. And the 2 examples that I can think of immediately, and you know this, is chickenpox. You get chickenpox as a child, you get over with it fairly quickly. You get chickenpox as an adult, you have a very bad course of infection. The second is hepatitis A. People who are growing in India, almost everyone by the age of 10 has had a hepatitis A infection, and they are over with it. The antibodies they get are protective for life. But if you grow up in an environment where you grow up on bottled water and you get this infection when you are an adult, hepatitis A can be a very bad infection. So this is not something unique to this virus. Now, as far as old age is concerned, you have to realize that old age, people of older age have accumulated a lot of other diseases. They have high blood pressure, they have bad lungs. People growing up in polluted cities, people smoking, they have bad lungs. This virus affects the lungs. So comorbidities accumulate as you grow older, and that's probably why you're getting far higher mortality during, in old age than you get in younger people.
We do have like lots of questions coming in. I don't know how many we would be able to take, but Shubhra, I'll give the thing to you. I just wanted to add two questions, three actually, which have come from people here. How effective do you, okay, how effective they expect the government's response systems to be so far, and what more needs to be done to curb the spread of the virus here? In terms of research, what should be the main priority for India right now? Should we focus on diagnostic first, vaccines, or building capacity in ventilators, etc.? And to add to that, now that the government has widened the testing criteria, are we fine? Does the criteria need to be further broadened? And what should be, if you could be very specific around what should this criteria be, and what are your suggestions as experts?
So Shahid, which ones are you taking?
The research one.
Okay.
You do the government one.
Okay, I'll do the government one and the criteria.
Go ahead.
Go ahead, Cherry.
Okay, so in terms of the government response, so in, at least initially, I think the thing to understand is how quickly you need to move in a pandemic. And we've seen over the last few days a rapid acceleration in how the government is responding. So if you look at what governments have done in other places, you look at Singapore, you look at South Korea, they have not shut the country down. They have focused on an approach where they essentially tested lots and lots and lots of people. They identified the infected people, they isolated the infected people, and they made sure that their contacts were followed up well. So if you look at what our government started to do, it was exactly the same thing: identify infected people coming in, follow their contacts, and make sure that things are going well in terms of isolating the contacts and following them up. But very quickly after that, we started to see these stories of so-and-so escaped from quarantine, that, people hid their travel histories, that a lot of things happened that made us very insecure about the ability to identify all cases that were coming into the country and the ability to trace all contacts. So in response to that, we are in the situation that we are in today, where we are trying as much as possible to limit people interacting with other people. I think one of the things reflects back on what people had asked about the age structure. I had referred to that at the disease level. I did not talk about it in terms of transmission. Who are the sources of transmission? The sources of transmission are largely young people and working people, because it is the young in schools and in colleges who have a lot of interaction with each other, and working people, whether it is formal or informal sectors, also have a lot of contact with each other. It is that person-to-person contact that spreads disease. So the idea of the shutdown, the idea of limiting travel is to say, stay in place. Stay in place for as long as it takes for disease to manifest itself. And then we need to be ready to test. So if you have a baseline where you say for 2 weeks, nobody is going anywhere, anybody who develops symptoms will be tested. We will find whether they have coronavirus or not. And because they have stayed in place, the number of contacts that they have is relatively small. So then you will be able to limit you can quarantine their contact. If you let everybody right now move around as much as they want, contact people as much as they want, this will rapidly reach a stage where we won't be able to test people, where when people get sick, we won't have hospital facilities available. We won't have enough ICU beds available. This is the big worry. And right now, because we don't have data, we don't know what we are dealing with. So this lockdown, shutdown that the government is doing is exactly the right thing. What we need to get out is the message to people everywhere saying as far as possible. And this is not as far as possible to make your life comfortable. This is as far as possible treating your own self and your family as a potential source of infection. Try not to infect other people. If we can do this initially for a short period of time, that will buy us enough time to build the systems that allow us to test and to treat. So this is very important. What the government is doing is the right thing. We need to trust that, and we need to make sure that we enable people to be able to comply with these requirements. My biggest worry right now is what it means for people who live in places where isolation is difficult, where all the instructions around hand washing are difficult, where you may not have a toilet in your home, you need to be moving out. How do you communicate with them? What kind of messages do you give to them? And I think thinking through what advice we can give that is practical, that is actionable at a very, very granular level. If you don't have water, what can you think about doing? You could think about designating paper towels, a piece of cloth that you use to touch frequently touched objects. When you can, if you can't wash your hands 10 times a day just because you don't have enough water, wash them and then be careful about what you are touching. When you think about children running around the place, playing with other children, in a street that is very difficult to limit, but this is the time when we have to be thinking about doing these kinds of activities, not allowing too many person-to-person contact at this time. This is temporary. It feels really long. We have never done anything like this before, but this is very, very important. So Shubhra, I think, in terms of how regional media should be communicating or how they should address these issues, you'd be the best positioned person to answer that.
Not an expert, but I'll try, specifically because the regional media is a different ball game altogether. And what questions we are asking of either the authorities or globally to experts are not are sort of out of access for the regional media, and many times they rely on reports from the national media or openly accessible press conferences or stuff to report on the ongoing crisis. So the questions that really the regional media should also be asking now are the ones that are specific to India, rather than, in a broader sense, like you mentioned, what happens in our own gullies, how to restrict those children from playing in the gullies, or how to not let the agricultural workers go into the fields right now, or how to really limit that section of women whose livelihoods are dependent upon, say, fisheries, or even smaller scale operations. So those are the questions that we should be asking. And in India, we don't really yet know the rate of fatality, despite all the modeling and despite all our guesses, or whatever you have. It requires the numbers of how many people are infected, how many have died, to really impress upon also the regional media to take action. Unless we really know the gravity and enormity of the situation, and it comes upon the journalists really to figure that out. So that is one thing I would think that we need to look at, the enormity. We don't yet know also the serious, if there's any serious local transmissions happening, the testing at the scale that is required, the virus's incubation period. For instance, many people thought that one day of thali banging might take the virus away from the system, and so the next day you're virus free. And we saw what happened after the 9 p.m. curfew. So, and that was the question that many people also, many journalists also, regional media journalists also asked me, that now that we have this one-day curfew, so can we go back to our, back to work the next day? Or should we start reporting from the field like we did earlier? I mean, many were taking precautions till then, and suddenly you let loose everything and don't think of the incubation period of the virus at all. So yeah, those are the questions we need to be aware of. We don't yet have the genomic sequences that show us how the virus is evolving, mutating, or spreading in India. Although interpreting those sequences can be a challenge for researchers, I understand that. Given these uncertainties, I think the fact that still remains in the regional media is experts suggesting that the public will have to be informed about the limitations of numbers and other factors. So what are the numbers we are dealing with? What are the other limitations of this story? That these are the things that we need to get across through the regional media. Also, repeatedly carrying the news about hygiene, as you mentioned, social distancing, how the virus spreads through aerosol droplets that comes from infected persons, and the need really to emphasize in every story that you write, even if you have told that 1,000 times earlier, there could be a reader or a viewer who's coming in just today to that story, having seen the paranoia around him or her, is just coming in today. And so emphasizing that message whenever you can, with whichever story you can. There was also a question through the listeners of this webinar on the statewide figures in the regional press. So that is also important for the regional press to highlight, about how many people are dying in the state, how many are infected in the state every day. And so if we miss that figure even for a day, then we are just loosening the enormity and gravity. About the urban slums, what is happening there? The gender story, about the universities closing down and asking students to go home. What do they do? What do these students have to do in such a situation? What are the daily wage laborers in cities like Mumbai, Pune, who had to flee those states, within 24 hours of notice? What exactly can they do and should do? These are the questions I think are very pertinent at a very local level to be answered. Shayad,
So
I'll let you answer the other
yeah, there was a
questions.
question about what more, and the options that were given to us were research, developing diagnostics, vaccines, capacity building. We are in the middle of a pandemic. So the most urgent thing is to do capacity building. We ensure that we have enough hospital beds available. We ensure that we have enough personal protective equipment to our health workers. And there's been some things written in the media about how personal protective equipment are not available to healthcare workers. That puts them at a very, very big risk. Getting ICUs ready, making sure there are enough ventilators. So there's no doubt in my mind that in this situation in which we are now, we need to build capacity to treat people. That should be our top priority. Diagnostics, yes, diagnostics. If we can come up with very quick diagnostics, the world is coming up with 30-minute tests and 45-minute tests. Those need to be verified whether they work as well. But I don't really think we should really be spending too much time developing diagnostics at this point. Vaccine, Cherry has already talked about this earlier. Vaccines are being developed, and vaccines are not going to be a solution for the near term. The closest vaccine is about 18 months away. So this is really not the time for us to be developing vaccines. For research, I think the most important thing is cooperation, collaboration. This is an opportunity to do some really good research, and there is low-hanging fruit out there which we can pick. But the important thing is for us to collaborate. And I will give a few examples of such low-hanging fruit. One which was mentioned is the sequences of Indian viruses. The world has now put over 950 different strains of the COVID virus in the public database. A country of India's size capability has put only 2. We have no idea about how the virus is evolving in the country. And it's not because there is not enough expertise in the country to quickly sequence and do the bioinformatic analysis that is required. We have the capacity. It's just that nobody has access to the virus. The virus is there with NIV and ICMR, and nobody else has access to it to be able to sequence it. We can, for example, there are labs that have containment facilities that can grow the virus. Now imagine, and this is, by the way, a fairly easy virus to grow in culture. Now imagine if, 10 labs, 20 labs in India had the culture going, each one of them could be testing a whole bunch of molecules on this. And somebody may come up with a very nice hit. Somebody may come up with a hit of an existing drug, just like you're talking about chloroquine today, that could be mobilized. So, these are opportunities we always lose because there is a reluctance in the country to share. We need to be working together in situations like this, not just in situations like this. I mean, we just need to be working together, and we just don't do that. So if there is one research lesson that I think we ought to learn from this, is that we need to be working together. We need to be mobilizing whatever resources we have available, whatever resources capacity has been built in peacetime has to be mobilized now. If we're not doing that, we're not doing service to anyone.
I do have a few questions which have come from some of the community media partners who've joined the call. And this is basically asking कि अगर घाव चोट है और वहाँ रक्तस्राव है तो क्या वायरस वहाँ संक्रमण कर सकता है? They also want to understand the various modes of transmission. If we can answer this in Hindi, that would be helpful. And in addition to that, there is also a question which talks about that recently there have been talks about the virus being airborne. Initially, the idea was that it wasn't airborne, but now there are rumors or actual news of it being airborne. If experts can talk a bit about that.
So in terms of, let's take both transmission as well as points of entry and what you can test for the virus. अगर आप देखें वायरस कैसे आता है तो बिल्कुल अगर किसी को खांसी हो तो वो वायरस फैलाते हैं. अगर खांसी ज्यादा हो तो ये ज्यादा फैलता है. अगर ये ड्रॉपलेट इन्फेक्शन हो तो ड्रॉपलेट्स भारी होते हैं, ज्यादा दूर नहीं पहुंचते हैं, पर जब किसी सरफेस पे जैसे कि टेबल पे, कपड़े पे, कार्डबोर्ड पे पहुंच जाते हैं तो वहां पे 1 या 3 दिन तक रह सकते हैं. जब आप एरोसोल ट्रांसमिशन को देखो तो ये एरोसोल ट्रांसमिशन ये ड्रॉपलेट इन्फेक्शन से छोटे होते हैं और ज्यादा देर तक नहीं रहते हैं हवा में. पर अगर किसी ने एरोसोल से ट्रांसमिट किया हुआ है, तब आप अगर कॉरिडोर में चल रहे हैं या कहीं भी हो जहाँ पे एरोसोल ट्रांसमिशन पहले आधे घंटे में हुआ है, तब वहां पे इन्फेक्शन हो सकता है. तीसरा रूट जो इन्फेक्शन का है ये किसी चीज को छूने से होता है, और जब हम खांसते हैं या बहुत बात करते हैं तो वायरस निकलता है मुंह से, और ये हमारे हाथों पे भी पहुंच सकता है, और जब हम हाथ से किसी चीज को छूते हैं तो वहां पे वायरस छोड़ सकते हैं, और कोई और अगर आके उस चीज को छू ले उनको इन्फेक्शन हो सकती है. उनको उसके बाद छूने के बाद अपने मुंह या नाक या आंखों के पास अपना हाथ लाना चाहिए, तब इन्फेक्शन उनको हो सकती है. तो ट्रांसमिशन जो होता है ये ड्रॉपलेट इन्फेक्शन से हो सकता है, एरोसोल ट्रांसमिशन से हो सकता है, और ये किसी चीज को छूने से हो सकता है. इसको कहते हैं फोमाइट ट्रांसमिशन. ये 3 तरीके हैं वायरस को अंदर आने के लिए, और जब आ जाता है ये पहले रेस्पिरेटरी ट्रैक्ट में आता है, तो लंग्स में इन्फेक्शन हो जाती है, पर ये जो रिसेप्टर्स होते हैं वायरस के जो इनको सेल से बांधने देते हैं, ये हमारे लंग्स में मिलते हैं, और ये वैस्कुलर जो ब्लड वेसल्स होती हैं उनमें मिलते हैं, और गट में, जैसे कि I don't know what enterocytes are, but ACE2 inhibitors ये एंट्रोसाइट्स में भी मिलते हैं. तो ये वायरस जब आ जाता है तब क्योंकि ये लंग्स और ब्लड वेसल्स में जा सकता है, इसकी सर्कुलेशन भी होती है, पर ट्रांसमिशन के लिए ये ज्यादातर लंग से ट्रांसमिशन होती है. और अभी तक जो स्टडीज हमने देखी हैं कि जब गट में इन्फेक्शन हो जाती है और स्टूल में वायरस निकलता है, पर वो अगर उससे इन्फेक्शन हो सकती है ये हम अभी तक नहीं कह सकते हैं. कुछ टेस्ट हो रहे हैं जो अभी तक हुए हैं स्टूल सैंपल्स पे, वहां पे वायरस का आरएनए मिल जाता है पर पूरा वायरस नहीं मिलता है, तो इन्फेक्शन उससे नहीं होती है. तो इसलिए लोगों ने पहले भी पूछा था कि सैनिटेशन के साथ क्या हो सकता है. अभी तक हम जानते नहीं हैं कि अगर ओपन डेफिकेशन हो रही है तो वहां पे वायरस मिलेगा या नहीं, पर ये जो टेस्ट हुए हैं बहुत ही कम पेशेंट्स में हुए हैं और हमें और करना चाहिएगा, उसके बाद हम कह सकेंगे कि क्या हो रहा है।
मैं एक बात इसमें ऐड करना चाहूँगा कि एरोसॉल ट्रांसमिशन जो है वो WHO का अभी भी ये मानना है कि ज़्यादातर इस वायरस का ट्रांसमिशन ड्रॉपलेट से हो रहा है। मतलब अगर आप छींकते हैं या खांसते हैं और किसी सरफेस पे आपका थूक रह जाता है, उससे हो रहा है। एरोसॉल ट्रांसमिशन से अभी भी WHO का ये मानना है कि बहुत महत्वपूर्ण तरीका नहीं है एरोसॉल अभी भी इस वायरस को ट्रांसमिट करने का।
That's absolutely right. So it's a minor mode of transmission.
Thank you. We do have some questions around, is there a high probability of community transmission already having started in India, especially considering certain evidence like the Tamil Nadu case or death of few elderly in private hospitals? Should India allow testing kits from countries like China, South Korea, which don't have US FDA and EU CE certification? And should India start conducting widespread rapid testing like South Korea is doing?
So if I can take that, it's likely that we have community transmission given that we have cases without a known contact history. The extent of that community transmission, we don't know yet. Speaking from just looking at whether hospitals are admitting large numbers of cases that have severe respiratory infection, patients who are on ventilators, I think every hospital always functions at capacity. So it's a little difficult to test until we start to get data from testing patients who are currently admitted with severe respiratory infection. You must remember that this new testing regimen was liberalized only last week, and laboratories were unable to test until the notifications went out over the weekend. So in the next week or so, we are going to have a lot of laboratories ramping up capacity to test. I hope that they will be testing all of their severe acute respiratory illness patients. That will give us a sense of how much is out there. We need to start now, we need to continue. But after we get going in hospitals, we also need to be looking at what testing needs to be done in the community. This will give us a sense of how big the problem is, and as we keep doing it over time, we will get a sense of trajectories as well. That will better inform models and allow us to make predictions about where we need to be emphasizing stronger responses.
And I agree there. I do believe that community transmission is happening. We are right now unable to measure it because we are not testing at scale. And it is really unreasonable to believe that in an outbreak like this, community transmission won't be happening. If you simply look at the numbers that are being reported on a daily basis and see the, how steep the curve is becoming, it's hard to believe that community transmission is not happening. But we shouldn't be alarmed about it. We should gather evidence and we should build proper contingencies for it. And as Cherry said, many more labs are going to be now testing. So one hopes that there will be more reliable data in terms of numbers, because for a country of our size, the testing really has been limited.
We still have questions pouring in, but we're running short on time. Right. So Shubhra, I'm going to ask you a question probably. Okay. So what special precautions should reporters be taking while covering the pandemic to ensure they don't get infected? Masks, sanitizers, hand washing aside, are there any specific precautions that they can take while they're on field work?
Well, that's more or less it in these given circumstances. But however, the aspect that we forget about journalists covering this pandemic of such a huge scale is the kind of mental health trauma they go through, reading up such huge amounts of literature every day, and not so wonderful news. It has an effect on you. So in the newsrooms in India, I haven't seen too much of sort of being very careful about the mental health of journalists covering this kind of a pandemic. So I would suggest that apart from taking all the basic hygiene, distancing, everything, all these precautions, I think you should also get away from your work once a while, if your newsrooms allow, and ask them to allow you to do that. Even if your bosses are not cooperative, you have to make them see how it is impacting you, your family life, your entire being, because apart from being just professionals, they are also people. So get away from your desks, take brief breaks, look outside. It's way more lovelier, blue skies and good air to breathe now that the streets are empty. So life continues, and try talking to your colleagues who are also covering the pandemic, and try talking to them often to feel not so um, overwhelmed with the kind of work you have to do. If you have an editor, a peer, a spouse, a friend, you must trust somebody to listen to you and not pass judgment on you on how you're doing things. And perhaps the best thing I can guide everybody to is the DART centers, self-care amid disaster for journalists. How you need to eat healthy, how you need to be at the right spot at the right time, and yet be on top of things, de-stress, etc. So I think apart from hygiene, take care of your mental health as well.
Thanks so much. We have one question on herd community. So if you guys can sort of help us understand, is herd community eventually going to really happen in the near future? And if that also, probably you can answer part in a bilingual manner, that would be helpful, because the question is to sort of understand what is herd community and if that can help in near future.
So would you mind if I 30? Okay. So अगर आप देखो कि वायरस किसको इन्फेक्ट करता है, हर रोज हम बहुत सारे वायरसेस देखते हैं, बहुत सारे बैक्टीरिया देखते हैं, हर दिन बहुत इन्फेक्शंस होती हैं। ये वायरस क्यों अलग है? ये वायरस अलग है क्योंकि ये नया वायरस है, किसी को इसने नहीं देखा है पहले। दूसरे जो वायरसेस होते हैं हमने बहुत बार देखे हुए हैं, और जैसे कि आप सोचिए जिस वायरस पे मैं काम करती हूँ, ये रोटा वायरस है, बच्चों को होता है। अगर बच्चे एक बार, दो बार, तीन बार इस वायरस को देख लेते हैं या उनको वैक्सीन दी जाती है, उसके बाद उन्हें इस वायरस से दस्त कभी नहीं होता है। तो हम अगर किसी भी वायरस को एक, दो, तीन बार देख लें, उसके बाद जो बीमारी होती है वो ज्यादातर बहुत ही माइल्ड रहती है या होती ही नहीं है। इस वायरस के साथ भी शायद यही होगा, क्योंकि अगर इस वायरस को हम एक बार देख लें तो हमें थोड़ी देर के बाद इससे थोड़ी इम्यूनिटी हो जाएगी, अगली बार जब हम वायरस देखेंगे तो जो असर वायरस का होता है वो कम हो जाएगा या नहीं होगा। ये हम जानते हैं क्योंकि कुछ स्टडीज अभी भी हो गई हैं जो लोगों ने बंदरों के साथ की है। जब पहले वायरस दिया गया तो बहुत बीमारी हुई थी उन बंदरों को। दूसरी बार 1 महीने बाद जब वो वायरस फिर से दिया गया तो कुछ बंदर बिल्कुल इन्फेक्ट नहीं हुए, और जो इन्फेक्ट हुए उनमें जो बीमारी थी बहुत ही कम थी, थोड़ा सा बुखार हुआ था और कुछ नहीं। तो लगता है कि इस वायरस के साथ जब एक बार इन्फेक्शन हो जाए तब उसके बाद थोड़ी प्रोटेक्शन होगी, बीमारी ज्यादा नहीं होगी। पर अगर हम देखें किसको इन्फेक्शन होती है, हम सब, ये नया वायरस है तो हम सबको इन्फेक्शन कभी ना कभी हो ही जाएगी। शाहिद ने पहले कहा था कि ये इन्फेक्शन शायद 25% देश में हो जाएगी, दूसरे लोग कह रहे हैं कि आधे लोगों को हो जाए ये इन्फेक्शन होगी, कुछ लोग कह रहे हैं 80% लोगों को होगी। जब ये इन्फेक्शन होगी क्या होगा, ज्यादातर सिम्टम्स बुखार और खांसी रहते हैं, और जो लोग युव हैं, बच्चे हैं, उनको ज्यादा इन्फेक्शन, ज्यादा बीमारी नहीं होगी, 1 हफ्ते के बाद ठीक हो जाएंगे। उनको उस वक्त इम्यूनिटी हो जाएगी क्योंकि एक बार उन्होंने ये वायरस देखा है, अगली बार जब आएगा उनको इन्फेक्शन नहीं होगी। जब उनको इन्फेक्शन नहीं होगी ये वायरस नहीं फैला सकते हैं। तो अगर एक पॉपुलेशन में आप देखिए कि 100 लोग हैं और 80 लोगों ने ये वायरस पहले देखा हुआ है, तो सिर्फ 20 लोग रह जाएंगे जिनको इन्फेक्शन हो भी सकती है, और ये जो 80 लोग हैं ये इन्फेक्शन को फैलाएंगे नहीं। अगर ऐसा होता कि 10 लोगों को इन्फेक्शन हो जाती है तो 90 लोग ससेप्टेबल रहते हैं, उनको इन्फेक्शन हो सकती है। तो जैसे पॉपुलेशन में ज्यादा परसेंटेज इन्फेक्ट हो सकती है, ये वायरस कम फैलेगा। ये प्रिंसिपल है हर्ड इम्यूनिटी का। पॉपुलेशन को हर्ड कहते हैं, और जैसे ही पॉपुलेशन ज्यादा इन्फेक्शंस हो जाते हैं, ये जो वायरस है इसकी ट्रांसमिशन कम हो जाएगी, ये वायरस कम फैलेगा। Okay,
Thank
with
you,
that,
Dr.
yeah,
Thank
I'm
you so
sorry
much.
to drop off now, but if there are questions, please send them to me by email and I'll try my best to get back. Thank you and bye.
Thank you so much.
I will say one last thing to people who are already there. Please don't forward anything and everything you get on social media, either WhatsApp or Facebook. And please, for your mental health, for the mental health of your contacts, take frequent social media breaks. It will help all of us deal with the situation much better.
Shubhra and Dr. Jamil,
I totally agree.
Great.
I totally agree to
ask,
that, and I think that as I said, the skies are blue, our hearts are warm, and it's given us a chance to discover our family better and further. Though I'm told that for some families it's not such a good chance, but and things are spiraling out of control of living together. But then it's a reason for introspection, isn't it? So we will ride over the pandemic at some point of time, and so let's use this time staying at home, making the best use of the time that we can, staying right back in our bedrooms or our living rooms.
Thanks, Shubhra. Thank you, Dr. Jamil. Thank you for agreeing to do this on a very short notice and finding time out and for clarifying so many questions that have been bugging, I'm sure, many of us. We are all learning each day, and there are so many more things to understand and explore when it comes to COVID-19. And this was very helpful. We still see comments coming in, and I would also like to thank Hina and Yukti from India Alliance, who have been a great support in putting this together. We do hope to hear from all the participants about how they felt about this webinar. We plan to host more in this series, and your feedback would be deeply valued. Please do let us know how you feel we can improve on this. What are the topics you would like the experts to discuss? And do take very good care of yourself and your loved ones. We are all in this together. Thank you. Thank you, everyone.
Thank you.
We have some information here on the screen, if you guys can look at the screen, and we will be sharing these resources to all the people who have participated. Thank you so much, everyone. I can't bloody close this thing. Hello.